I'm going to go ahead and get started. Good afternoon, everyone, and thank you for attending this ImmunoXX Plus virtual mini symposium on COVID-19 research progress. My name is Casey Beppler, and I'm joined by my fellow grad student, Erin Huding, and we will be moderating today's talk. We hope everyone is staying safe and staying well in these difficult times. Before we start this virtual symposium, we wanted to take a moment to address the ongoing racism and police brutality in the United States that has rightfully escalated into nationwide protests. We want to first say that ImmunoXX Plus stands in solidarity with the Black Lives Matter movement, and we encourage everyone here today to visit our Twitter thread where we have compiled resources to support this movement. We encourage you to donate if you can, sign petitions, educate yourself on the issues, share these resources with others, and work hard for effective policies today and days to come. As an organization founded on promoting diversity and inclusion, we understand that the scientist cannot be separated from the person. We need to recognize when members of our community are hurting and ensure that we're doing everything we can to support them. Right now, there is a spotlight on the pain and racism that Black people experience every day in the US. We acknowledge that it's extremely challenging to focus on work and science, so we are especially grateful to our speakers for taking the time to share their research with us today. We hope that this symposium will highlight the necessary COVID-19 work being done by an outstanding group of researchers. Thank you, Casey. So in organizing this symposium, we thought it was important to amplify the work and voices of women across different fields of COVID-19 research, as they are often overlooked in press coverage or not respected as the experts they are. We're excited to see that over 600 people have registered to attend the symposium, and in an effort to make available to all, we will be recording this event and sharing it online. One silver lining of the recent move towards virtual events is the increased access to research seminars. If you find the symposium useful, we strongly encourage you to explore other opportunities to learn remotely, such as the Keystone Symposium on Vaccinology in the Age of Pandemics, as well as several other symposiums listed here. We'll be sharing a more comprehensive list following the event if you'd like to take part. And today, following each research presentation, we'll have time for 1 or 2 questions from the audience. And at the conclusion of our 4 presentations, we will hold a panel discussion, during which time we will follow up with additional questions submitted from our audience or fellow panelists. Questions may be submitted using the Q&A function at any time, and please note if you'd like to direct your question towards a specific person. Thank you again for taking time to attend our virtual research symposium, and it is with great pleasure that I introduce our first speaker, Karen Sugar. Karen has been a mentor to me for over 10 years and has made meaningful, long-lasting contributions to the livelihoods of young girls and women worldwide. Specifically, Karen is the founder and director of Women's Global Empowerment Fund, a nonprofit organization that ImmunoXX Plus has partnered with to highlight their work fighting the COVID-19 pandemic in their communities across northern Uganda. We highly encourage participants to donate in order to support their ongoing and future work. Thank you, Karen, for taking time to join us today, and we welcome you on behalf of everyone.
Well, thank you. I love that Erin invited me to this and introduced me. She started working as an intern when she was 15 in our Colorado office, and I have great affinity and respect for her and the amazing young woman that she has become. And I really appreciate everyone, including me and Women's Global, in today's symposium. I'm just hoping I can keep up, as I am not a scientist. And I really appreciate your commitment to solving one of the critical issues of the day. These are historic times indeed, and the inspired activism, civil disobedience, diversity of voices, and passion in the last week to denounce the murder of George Floyd, demanding an end to police brutality, inequality has given me hope that we can have a nonviolent revolution for racial, economic, and gender justice, which are issues that I work on every day. I believe the pandemic has pulled the curtain back even more to expose the disparities in our society. One of the quotes that I use in my work and my teaching is by John Kenneth Galbraith. All successful revolutions are the kicking in of a rotten door. And I think we have all seen the rotten door. And I feel that there is this momentum to to addressing the issues. And I think it can be an exciting time. What I know from working in a post-conflict region is that sometimes when things seem the most broken, the most scattered, there exists unique opportunities to create something new and meaningful based on social justice. Women's Global Empowerment Fund is a 501c3 nonprofit that creates innovative economic, social, and political opportunities for women and families in a post-conflict region in northern Uganda. Those opportunities include literacy, a unique microcredit lending model accompanied by business and leadership development projects. Health initiatives, we have a Healthy Periods initiative addressing menstrual health issues, which is critical to dignity, health, keeping girls in school longer, and that has become one of our most important programs. We also do education around sexual violence. We have social justice initiatives and more. WGEF helps create ways for communities to transform themselves, to becoming their own advocates and creating their own solutions to move their own communities forward. WGEF is a vehicle for creating sustainable human development in this region in an intimate, meaningful way from the ground up. In response to the pandemic, I mean, we're not a health-based organization, primarily anyway. You know, it became, what can we do? How can we be a part of the solution? Because we knew that the impact of this virus could potentially be devastating in northern Uganda, where the communities are very under-resourced. So we started really from the ground up to work to reduce the spread and address the indirect challenges to people's lives and health. Under-resourced communities have unique challenges with little access to basic human resources, including soap, water, access to medical care, hand sanitizer. We have created a locally sourced and produced inexpensive hand sanitizer. We call it Lucky Hand Sanitizer, and are producing and distributing the product to community leaders, first responders, the task force that are working hard, our staff, our leaders, and it's in our centers and offices. And we're delivering it to our families in villages and districts across the region. One thing I didn't expect when I sent the homemade hand sanitizer recipe to my program director, who's amazing, was that we would become the only place in town that was making this product, where people were able to access it. So we're inundated with requests for this. So we now have, 3 sizes. We're distributing it and making it as quickly and exponentially as we can. And then in addition to that, we're also distributing our locally made, locally sourced sanitary products to girls who are at home. So there are many indirect spirals of the virus during the lockdown. A quote from a schoolgirl named Milan: "We used to get sanitary pads from my school in a Chet district. Now that schools are closed, I'm in my village with no access to sanitary pads. I have to use pieces of newspaper, which is very uncomfortable. I feel sad and embarrassed. I'm afraid to sit down for the possibility of soiling my clothes." So our Healthy Periods initiative is now delivering, we deliver pads to 16 schools across the region every month. And now that girls are home, they don't have that access. So we're not only delivering hand sanitizer, but we're also delivering packets of pads, as many as we possibly can to as many villages as we can. We want to make sure that girls and women can manage their menstrual health with dignity. And the goal of the Healthy Periods initiative is to keep girls in school longer. The third major reason that girls drop out of school is menstrual health. So it's a win-win for everybody if we can keep girls in school longer. And in addition, we're keeping Gulu Women's Resource Center open because, as we know globally, there's an uptick in gender-based violence. So during the lockdown in Uganda, during the sheltering in place in the United States and really around the world, oftentimes women are now forced to remain home inside with their abusers. And it's really an awful and challenging problem to address. So we've kept our resource center open with our peer counselors and our Access to Justice team members. We've been making home visits, and our toll-free hotline has experienced a 300% increase in calls during this time. So it's really critical that that women have the resources and the support they need during this lockdown. And Women's Global, as small and grassroots as we are, we're trying our best to keep up with all of that. So while I know that today I will learn and be inspired by all of you, I'm also hoping that you would all consider making a small contribution to ensure that we can continue to provide these services and distribute hand sanitizer and our sanitary products to girls at home, and promote health and dignity for girls, women, and communities across the northern region of Uganda. So thank you again for including me, and please reach out if you have questions.
Karen, thank you so much again for sharing your work with Women's Global Empowerment Fund. We would like to echo that both global and local communities are experiencing extreme challenges with COVID-19, and we encourage individuals to continue donating to both global and local organizations that address COVID-19 and support communities of Black, Indigenous, and people of color. And now I would like to introduce Dr. Carina Marquez. Dr. Marquez is an infectious disease physician at UCSF and the Zuckerberg San Francisco General Hospital. She is committed to disrupting the transmission of COVID-19 and is an ardent advocate of equitable healthcare, and has been instrumental in the fight against HIV, TB, and now COVID-19. Welcome, Dr. Marquez.
Thank you so much. Let me load these slides. All right, so thank you for having me. It's such a pleasure to be here and be on this panel. And I'm here today to share data from our community-based study called Unidos en Salud. This is preliminary data. And I hope today to be able to highlight sort of the impact of COVID-19 on communities and sort of think about how we can use research to inform action. So this is, before I get started, I want to just emphasize this is a preliminary report. So this is all preliminary data and it hasn't been published yet. And then I am just one of a very large team of researchers here that you can see below, including our UCSF team at UC Berkeley, the Chan Zuckerberg BioHub, and most importantly, our community partners, the Latino Task Force on COVID-19, and the city, including the Department of Public Health at San Francisco, and also our city supervisor, Hillary Ronan, of District 9. Okay. So let me get into a little bit of the background. So why are we focusing on the community level? So early in the response, COVID-19 tests were limited to patients with symptoms and people with severe disease. And so we really only had an understanding of what was going on in the hospital for patients who were coming in quite sick. But we know that hospitalizations are really just the tip of the pyramid. And testing and responding to persons in the community before they are hospitalized we think can accelerate epidemic control. And so with this in mind, we sought to understand COVID-19 transmission dynamics at the community level. A little bit more about our motivation and sort of how we chose the community and to start. So we know, I'm one of the doctors at San Francisco General Hospital, and what was very clear to us in the hospital, and I think what has emerged and is very clear now, is that community colors, and especially in San Francisco, the Latinx community, is disproportionately affected by COVID-19. This graph here just shows data, also unpublished data from Jane et al., looking at the proportion of the race ethnicity breakdown of our COVID positive inpatients at San Francisco General, and 84% of the cases were of Latinx patients. So we knew that disparities from the very beginning were massive, and we wanted to understand what was going on in the community level with the overall goal to really reduce disparities and continue to move towards health and health equity. So with those things in mind, our study objectives were, one, to inform and mobilize a population that is not being reached, not being reached by current testing and care systems. Two is to test, so within the community, to determine the active, so PCR positive, and prior COVID-19 infection, so with antibody testing, for all persons regardless of symptoms. And then thirdly, and also as important, is to respond, so to evaluate a novel community-based test to care program. And so these results that I'm presenting are just the PCR results. The antibody tests are coming out probably sometime next week. These data, these cohort will also be followed in the future, so more data to come. So how did we do the testing? So initially after a very intensive community mobilization phase with our community partners, we conducted testing at 2 elementary schools and 2 parks in the Mission District. And so this is just a map of the Mission District. Testing was focused on 1 census tract in the Mission. It's the second most dense census tract in San Francisco. It has over 5,000 persons, and it has the highest proportion of Latinx. We did testing from April 25th through 28th, and this was 6 weeks into shelter in place. And here you can see just the demographics of the census tract based on 2018 data, which has 58% Latinx and 34% had a household income less than 50. So I wanted to, and I think this theme comes out throughout the presentation, but the cornerstone of this study is that it was community-led and a product of multiple partnerships. And so just wanted to highlight the community partners. Before we even started community mobilization, we partnered with the Latino Task Force, which was a pre-existing group of Mission community-based organizations. And they partnered throughout the whole way on study design, figuring out how to mobilize the community. And you can see a picture here of many of the members of the Latino Task Force and UCSF outside of our headquarters. The Brava Theater became our sort of temporary headquarters. They sort of approached mobilization almost like a political campaign, so selling testing as their candidate. And we knocked on doors. I think they knocked on doors within the census tract 3 times. We put out ads on Spanish language radio. And then people mobilized their own networks. We had within the Latino Task Force, for example, the head of the day laborers organization, and he was out there talking to the constituents in his group, and so we were able to sort of really put a community face on this, and that was really essential to building trust and getting people to come. This is just a picture of the community mobilization and talking to people about the studies, addressing any fears or concerns they had, and then also at that time we were able to pre-register people. And so we're able to give them an appointment for the testing day. And then over here, you can see an example of one of the 4 sites that we had, where we had a massive amount of medical and community volunteers. And this is Flynn Elementary School, which happens to be my daughter's elementary school. But so a lot of people came out, and all the people that did the testing were actually volunteers. And we recruited and trained 450 medical and community volunteers. And we're absolutely overwhelmed at the support that we got within the UCSF and the community. So, so what happened? So with all this community mobilization, we were able to get a lot of people out for testing. And what we found is, yes, there was a high demand for testing in the community. And when we started this process, we weren't sure, would asymptomatic people come out? Because we were offering testing to people regardless of symptoms within the census tract. And I also wanted to note that people were eligible to participate if they lived or if they worked in the census tract. And then on the last day of testing, we expanded the area for people that weren't in the defined census tract. And so we had other people come to be tested. So within the 4 days of testing at the end of April, we were able to test over 4,000 people. And at that time, it had increased San Francisco's testing number of tests by 29%. So really amazing turnout And I think all due in part to the community team that was doing this and mobilizing folks. So as we're, one of the things in mind was we really wanted to get an understanding of not only mobilize participants or people who may not normally participate in, say, for example, an internet-based, population-based serosurvey, for example, but we wanted to sort of understand how the people that we got to testing compared with the census tract that we were trying to recruit. So here is who we reached. This is our testing coverage, and as of the total tested of 4,160, the people who lived within the census tract and worked within the census tract, there were 2,959 participants. The rest were from the expanded area and volunteers. And the demographics, we had 55% male, 45% female. And the majority of people testing were Latinx at 44%, and with 38% white, 11% Asian, and 4% other, 3% Black. And this, sorry, I don't have that slide, but when we looked at sort of how did we do, the coverage was about 60% of the census tract. So we felt pretty good about that. So we were able to reach about 60% of the people that that lived and were eligible for the study. So let me move to the results. So these again are the prelim data, and this is just looking at PCR positivity. And so here you can see when you look at the community total and look at just residents and workers who work or live in the census tract, 2.1% of people had a positive PCR or nasal swab test. When you just restrict that to the people who work in the area, it was 6.1% were PCR positive. And then when we looked at just the people, then when you just restrict to just who lived there, it was 1.4%. And then again, here we look at other groups of the people who lived in areas outside of the census tract, and it was also 1.4%. And others, volunteers, teachers, and other people that came to the study was less than 0.1%. So let me then now walk you through sort of information about the people who tested positive. So in these next slides, I'm going to compare sort of PCR positives to the overall study population. So to everybody, to the total population who came to the study, who lived and worked in the study. So I think one of the things that really came out to us is that, we're 6 weeks into shelter in place, but there are a number of people who do not have the privilege to shelter in place and are essential workers. So when you look at the 61 PCR positives, only 10% were able to work from home, and the remaining 90% still had to, could not work from home and were going outside the home to find employment or for their jobs. And this was vastly different from the overall population, which was 43% of people could stay home. So certainly a disproportionate burden on those who were unable to shelter in place. And so in addition to that component, we also looked at demographics, obviously. And so here you can see demographics of our PCR positive patients, and you can see that the majority of the PCR positive patients were male, so 75%. And then stark disparities are emerging. So 95% of people who were PCR positive were Latino, so which is markedly different from the total population. And so you're starting to see quite a disproportionate burden, especially on the Latino community. That is also notable is 5% of the PCR positive for Asian or Pacific Islander, and 0% were white, and 0% were Black. A little more data about demographics. So the majority of the PCR positives had a lower income of less than $50,000 in their household per year, and also had higher numbers of higher household sizes. So that's a little bit about the demographics. Another key question for us is that we wanted to really address is, can we rely on symptoms for testing yield? At this point, testing was restricted to people with symptoms. And that was quite different from the study, which we said all comers, we want everybody to come. And we do know that people who have can have detectable or transmittable virus when they're asymptomatic or when they're pre-symptomatic. So this was a key question for us. And these are data showing that that 53% of all PCR positive participants on the day of testing reported no symptoms. The common symptoms were not unexpected, but 33% of those with symptoms had cough, and what's not shown here is about 9% reported anosmia, so loss of taste or smell. Okay, so as mentioned, our study was not just about testing. It was also about responding to positive test results and really providing wraparound services for people who tested positive. And we knew, sort of early on that people aren't going to test, especially people who are asymptomatic, if they feel like there's only going to be negative ramifications, that they're not going to be taken care of, that it's going to have significant financial effects or health effects on them in the future. So this is just an example of, this is what we had designed for what we're calling the test to care model. And this is for people who test positive. So we had 3 arms of this, and one arm is just the San Francisco standard. We are lucky to have a fantastic Department of Public Health who's a partner with us in this. And the Department of Public Health provided their usual contact investigation, supportive services, contact tracing, as they normally do. And then in addition to that, our study team had 2 separate services that we brought to the table. The first was called the clinical response team. And so this was a hospital-based team. And in this situation was based at our clinic at Ward 86, which is the HIV clinic at San Francisco General Hospital. And in this, one of the nurses, it was a multidisciplinary team of nurses and social workers and MDs. And so with every positive result, when our nurses, who are very experienced in disclosing HIV results, called and disclosed the result to the participant, and then went through a whole education phase on isolation and quarantine, did an assessment of symptoms, and then checked in with the patient regularly to see how they were doing. In addition to this, we didn't want anybody to leave not connected to healthcare, and so did extensive work to link people to primary care. The other, and I think one of the most exciting features of our care model, was the community wellness team. And the community wellness team, this is Susana and Susie from the Latino Task Force, and this team was a community-led, community-designed team, and it was really to support people through the logistics of isolation and quarantine. And so Sara and Susana would call people who wanted services to really help them figure out isolation, quarantine. They provided cleaning supplies, masks, and food deliveries, and really helped support people to get through this very complicated process, especially in the setting of, as we saw in the mission, people living in very congregate living situations, multi-generational households, and people people to whom being stuck at home and not being able to, didn't have the resources necessarily to have meals delivered. So just to quickly touch on this model, and I like to show a lot of pictures, but this is Sara went from their community wellness team preparing food supplies. These are sort of just pictures of the like cleaning kits that people got right after their diagnosis. But we were able to reach 71 of 74 PCRs. I'm just noting that the 74 is a little different from the 61 because it includes the larger tracts or extended census tract. And what we found is that the majority of people did not have a primary care doctor. So only 30 of 71 people had a primary care doctor. And so our team is still actively linking people to care. And I think the reports of this, that households reported significant benefits of this sort of longitudinal support. It's not just one call for disclosures. It's like, oh, you're out of food, let me bring this, and help people. A lot of stories emerged over time as they built trust with the community and found someone who we thought was living self-isolating at home, but was really in an abandoned building. We were able to get him to a hotel, but all of that took time over many days. We were able to provide 250 persons with direct home support. So to conclude, so what do these data tell us? I wanted to just start with the notion that community-based, low-barrier testing is needed and is possible, but only with community partnerships. I think we would not have been as effective in getting people out unless they saw their trusted community members and who were explaining things to them about what would happen if you're positive and talking about the studies. And that trust helped to bring people out. And people wanted to know their status. So community partnerships is essential. And I think the low barrier part is another key point, because many people, and I think at this time to get tested, a lot of the access is through your healthcare system. And so for people who are uninsured and don't have a healthcare provider, access is really tough. But when it's in your neighborhood park, it's much easier to come. So that's one key component. And then secondly, in terms of what we are seeing about the burden of disease and sort of implications of transmission and sort of future public health interventions, what we found was over 2% of persons tested, and that's among people who live and work in that mission census tract, are PCR positive. And this was 6 weeks into shelter in place. And I think what was certainly heartbreaking for me, and I think tough to see, but were the stark disparities, and that low-wage Latino community members who are unable to work from home are disproportionately affected by COVID-19. And this is really mediated by so many of these, by pre-existing structural inequities, structural racism, components of the housing crisis in San Francisco. And so I think these disparities really came across. And then over half of the people, PCR positives, were asymptomatic. And I think that another key point is just that this testing would have failed to detect many, if we just relied on symptoms, we would have missed many infections. And then lastly, community testing in priority areas with the test-to-care interventions may accelerate epidemic control. And then I think I'm probably out of time, but I just wanted to highlight sort of how community-based data can this is a call to action. These disparities are certainly a call to action, and a lot of things have come out of this. And ongoing talks about low barrier testing, mobile testing are ongoing, and sort of thinking about the next phase to reach populations that aren't really reached. Legislation has already been happening where Supervisor Ronan has, based on these data, has introduced the Right to Recover Act, which will provide wage replacement for those who are not eligible for other sources of income, and wage replacement for people who are positive. And then thinking about how to adapt the test-to-care model and how to integrate community health workers with things like contact tracing and also to continue this care model. And then a lot of communities have rallied and want to do similar things. And so these pictures here are from last weekend, where the Bayview community rallied, and they did their own, in partnership with us, community testing campaign. And so those data are forthcoming. And I think I'm out of time, so I will end. But these are just all the many people that were involved in this effort. Thanks.
Thank you so much, Dr. Marquez, for sharing your work and all the work you're doing with the community organizations. I think it's really powerful and it's really important. We are running tight on time, so I'm going to leave the questions for the panel discussion. So I would like to take the next moment to introduce Dr. Ruby Yu, but I will wait for her share to share screen with her.
Can you see my screen?
Yes. Okay, so next I would like to introduce Dr. Ruby Yu. Dr. Yu is a leader on the COVID-19 testing project at UCSF to provide an ongoing resource for reliable COVID-19 antibody tests to inform the scientific and medical communities, policymakers, and the general public. She'll be presenting her talk titled Test Performance Evaluation of SARS-CoV-2 Serological Assays, and please welcome Dr. Yu.
Great. First off, I want to thank the organizers of the ImmunoXX Plus Symposium for putting this together and for highlighting women in the COVID research and response, and for inviting me to speak, and I'm really excited to be here today. So yeah, my name is Ruby Yu. I'm currently a postdoc in the Marston Lab at UCSF, and today I'll be talking about the work I did as part of a Herculean and collaborative effort across multiple departments at UCSF and Berkeley to evaluate the test performance of a dozen SARS-CoV-2 serological assays in an incredibly short amount of time, So we began this project on March 25th and posted our preprint and data online on April 24th. So I know that time no longer means anything to anyone, but if you can, try to remember back to 2 months ago around the end of March and the beginning of April. The global number of confirmed cases had just hit 1 million. States were just beginning to issue shelter-in-place orders one by one, and our PCR testing capacities were still severely handicapped. Amidst this backdrop, there came a surge of interest in serological testing as potentially our way out of this mess, and all of these headlines are from late March to early April. So why the interest in serology tests? As I'm sure a lot of you know, part of the immune response following infection is the generation of highly specific antibodies to the pathogen, which in this case is the coronavirus. And these antibodies stick around long after the pathogen is gone. So testing for antibodies can provide a molecular snapshot of previous infections or current infection, and hopefully immunity. And because of this, scientists and politicians started to turn to serological assays as a way to get a more accurate idea of the scope of infections. And also at the time, they were hoping to identify individuals who are immune and could safely lead to the reopening of economies, although the focus has really shifted away from this, more to seroprevalence studies now. So naturally, test manufacturers rushed to meet these hopes and demands. And when we began this project at the end of March, dozens of manufacturers were producing and marketing antibody tests, and governments were purchasing. But already, even very early on, there were indications that some of these tests might not be performing as expected, and they were failing independent validations after governments had already purchased tens of thousands or even millions of tests. So in the US, the FDA on March 16th published very flexible guidance on the marketing of serological tests. So this is a quote from the FDA commissioner explaining that manufacturers just had to validate their tests and tell the FDA that they had validated their tests, and then put a disclaimer to consumers that their tests aren't authorized by the FDA, but that was really it. They could still market. So in that context, there were a lot of unanswered questions about how reliable any of the available tests were. And this is where a big group of us, and I really want to emphasize that this was a huge collaborative effort, thought that we could provide some value as far as independent test validation data. So I just want to briefly touch on how these tests work, or how they're supposed to work, and where they can go wrong. This is not my normal area of research, so this was something I really had to learn about in order to do this project. So we'll look at lateral flow assays, which operate much like a pregnancy test. You typically load some serum, let it run out, and then see whether you have a test band that shows presence of your antibody of interest. So the way these tests are intended to work is that a positive test should always and only reflect people who actually have SARS-CoV-2 antibodies, which would be people with current or previous and happily recovered infections, and negative tests should only indicate individuals who have never been exposed or who don't have antibodies. But in reality, sometimes you have false test results. So people who have actually been infected will mostly test as true positives, but some will show up as false negatives. And just to clarify some of the terminology I'll be using, in the literature, you might see discussion of sensitivity, but in my talk, I'll be talking about percent positive, since we didn't have gold standards samples. And we're trying to measure the percentage of true positive test results among infected specimens, which in our case are samples that were confirmed PCR positive for SARS-CoV-2 and symptomatic. On the other hand, in a population where you know there can't have been infection, which for us are samples collected before the virus emerged back in prior to July of 2018, test results can show either a true negative or a false positive. And the consequences of a false positive for an individual would be mistakenly thinking that you've already been exposed to COVID and you're already potentially immune when you're not. In this case, when I'm talking about specificity, I'm talking about the percentage of true negatives determined using pre-COVID-19 specimens. So in our study, we evaluated the test performance of 12 SARS-CoV-2 serological assays, 10 lateral flow assays or LFAs, and 2 ELISAs, using 128 PCR positive samples from 79 individuals across multiple time points for some of the individual samples. And additionally, we used 108 pre-COVID specimens to determine specificity. And the goal here was to identify patterns and detection of antibodies across all of the tests, as well as to determine the accuracy and reliability of each individual test. So here I'm showing a summary of the data we collected from PCR positive COVID infections, grouped by days after the onset of symptoms. So most of the tests we evaluated gave separate results for IgM and IgG antibodies. And this top row reflects a positive test in IgM or IgG, which gave the highest percent positive. So you can see pretty clearly that the percentage of seropositive individuals increases by time after onset of symptoms. And while the exact numbers vary between tests, the trend is consistent across all of them. And these numbers peaked at greater than 20 days after the onset of symptoms, at which point 7 of the 10 assays have greater than 90% positivity. If we look at the IgM and IgG scores separately, we again see the same trend of increase in seropositivity with time, but IgM does show some higher percent positivity on average in earlier time points, but still really doesn't hit the maximum until the later time points over 20 days. But overall, IgM tended to be less consistent across assays. So here's the fuller picture of all of the individual test results for each specimen on each serological assay, grouped by IgM or IgG, and also grouped by days after symptom onset. So there's a lot going on here, but what I want you to take away from it is that you do, again, see generally similar trends across all the assays and general agreement between assays on particular samples. The percent of positive specimen rises with time, and you can also see on the left that the IgM results are less consistent than the IgG on the right. So here's another summary across all of the data using 108 pre-COVID specimens to determine specificity of each test. So there is higher specificity with IgG than with IgM, and overall IgM scores were less consistent, which ended up affecting the overall specificity that takes into account IgM and IgG. And again, here are the individual test results across all of the platforms. So some tests definitely performed better. You can see some basically blank columns, but there are also a few samples that tested positive by multiple samples, by multiple assays, which might be indicating some non-specific binding or some cross-reactivity to antibodies from other viruses. So just to summarize, out of the 12 tests that we looked at, there was heterogeneous performance, but a few of the tests did show high percent positivity in the PCR positive samples while maintaining greater than 95% specificity in the COVID negative samples. So I also wanted to bring up a real world problem of the lateral flow assays, which is that they promise to give this binary result of either positive or negative, band or no band. But the reality is that while these are qualitative and not quantitative assays, there's actually significant variation in the intensity of the bands. And if you look at the examples on the right, scores from 3 to 6, those bands are pretty clear. But if you look at the bands for the examples scored 1 or 2, they're pretty faint. And in particular, if you focus on 1, it's pretty hard to see, especially in a photo. And you really have to decide whether you're going to, where you're going to set the threshold for a positive result. So do you call this really weak band positive or negative? That has consequences for your measures of sensitivity or percent positivity and specificity. So to deal with that in a consistent manner, it's really important to train your readers, the people reading these assays, and to standardize your scoring of the bands, which we did with a 0 to 6 scale. So to look at the effect of different positivity cutoffs, we reanalyzed all of our data, counting weak bands as positive or negative. And here I'm just showing a representative lateral flow assay. You can see that the percent positive specimens, percentage of higher specimens is higher when weak bands are counted as positive and lower when they're counted as negative, as you would expect. And you see this same trend across all of the tests. Consistently, the percentage of positive specimens decreases when you don't count weak bands. So how does this affect specificity data? Across all of the different LFAs, you can see that specificity takes a hit with the squares when you count weak bands as positive. And in a number of assays, specificity increased substantially when weak bands were not counted, which are the triangles. So what this means is that you really need to standardize your scoring system for lateral flow assays and then set your threshold for positivity based on your needs. Is it more important for you to capture as many positive results as possible? In that case, you'd want to call weak bands as positive. But if it's important for you to optimize for high specificity, as is the case for seroprevalence studies where incidence is low, then you're going to want to call those weak bands negative. Some limitations of our study are that we had a limited number of specimens, of positive specimens at later time intervals, which limits our power. We had no specimens from asymptomatic or convalescent cases, and there's emerging evidence that suggests different antibody levels in those cases, which would be very interesting. And additionally, we didn't evaluate immune protection from future infections. So we don't know if the antibodies that are detected in these assays neutralize virus or provide any sort of immunity. And further work will need to be done to look at that. So to conclude, we evaluated the performance of 12 serological assays. We found that the percent seropositivity increased over time, peaking in samples collected 16 to over 20 days after the onset of symptoms, which matches other studies of serology kinetics. There was heterogeneous test performance among lateral flow assays and ELISAs, although there were a few assays that were able to balance a high percent positive with greater than 95% specificity. And an important caveat of the LFAs is the need to train readers and standardize scoring, and then decide where you want to set that positivity threshold, which influences sensitivity and specificity. So if you recall, in mid-March when we started this project, the FDA was allowing manufacturers to distribute pretty flexibly as long as manufacturers provided a disclaimer that their tests weren't authorized by the FDA. But on May 4th, in response to work from us and from others, the FDA ended up issuing much more stringent requirements for antibody tests, requiring validation on a standardized set of samples performed by the National Cancer Institute, as well as minimums for percent positivity and specificity. So again, I want to emphasize that this was a huge collaborative effort, not just in the Marsden lab, but across the entire immunology department, MSDP, lab medicine, and Berkeley. People helped with contacting test manufacturers to get them to send tests, handling the logistics of customs and test delivery. We had an army of volunteers to perform the test evaluation, lab medicine residents who did chart review, people who donated space and specimens. There were 72 authors on this paper with 37 affiliations who came together to get this done, from conception to posting results online in a month. And it was just an incredibly rewarding experience that I'm honored to have been a part of. Thanks.
Thank you so much, Dr. Yu. We do have time for a couple questions. So the first question is, your results largely looked at IgG and IgM. Since SARS-CoV-2 is a respiratory virus, why wasn't IgA included in your analysis?
The vast majority of the tests only look at IgM and or IgG. I actually can't remember any of the tests that were available at the time that we were collecting tests that looked at IgA.
Okay. The second question that we have is, did you think about looking at the same people tested for the serology test after 28 days to see if there's long-term and persistent immunization?
Yeah, that's something we would have loved to do, but with the way that we received the specimens, that just wasn't possible. And additionally, I think the patients may have been discharged. So that's something that we're really looking forward to seeing from other groups.
Great, okay, I think we have time for one more question. Okay, so can the problem with the LFA and band intensity be resolved by using a two-tier testing system, like what's used with some HIV diagnoses, i.e. following up with an ELISA or Western blot?
Yeah, I think that would resolve some of the issues, or additionally, even two different LFAs could potentially help resolve some of the ambiguities.
Great, okay, we will leave the rest of the questions for the panel discussion. So thank you for sharing, and both Dr. Hughes and Dr. Marquez, great presentations, and we really appreciate taking your time today to share your research with us. And now my colleague Casey will be continuing to moderate the upcoming presentation. So thank you again.
I'd like to introduce Dr. Kizzmekia Corbett. Dr. Corbett is a leader in the fight to design a COVID-19 vaccine from the NIAID Vaccine Research Center. Impressive beyond her years and passionate about helping others, her salient work led to and supports the first candidate vaccine in clinical trials. She will be presenting her talk titled Plug and Play Coronavirus Vaccine Development as Proof of Pandemic Preparedness.
Thank you for the kind introduction. So I am Kizzmekia Corbett from the Vaccine Research Center at the National Institutes of Health. And I'm going to talk a little bit about how we think about pandemic preparedness, particularly vaccine development for pandemic preparedness, and how years of work around other coronaviruses led to our vaccine development efforts here for the SARS coronavirus 2 pandemic. So I don't really need to explain this to probably most of the people in the audience, but coronaviruses are a global health threat, and they are a large family of viruses that are zoonotic pathogens, largely infecting animals. But there are some endemic human coronaviruses, 4 of which circulate in, seasonally amongst humans. Additionally, there are a few porcine coronaviruses that have been of particular interest to swine farms all over the globe. As well, as you know, there were previous coronavirus epidemics, the first of which was in 2003, which was the SARS epidemic that caused over 8,000 cases worldwide. And then also in 2013, there was the MERS epidemic that began and has since then caused over 2,400 cases worldwide. Now, when we say that coronaviruses are an imminent global health threat, so this slide I actually made in the beginning of my postdoc at the Vaccine Research Center, and it highlights 2 manuscripts that essentially told us that coronaviruses were poised for human emergence. And what that meant is that at any time, exactly what we're seeing now with the SARS coronavirus pandemic, this could happen. So the jump from an animal reservoir into humans was something that was imminent. And so we started to think about what that meant for vaccine development. And what we noticed is that what we needed was a fast vaccine technology, something that would be reliable. And italicized here is universal, because different fields think about universal vaccine solutions differently. But what I'm going to describe here is our thought around a universal vaccine solution that is essentially the plug and play model, where you can design an optimal vaccine antigen for one pathogen within a family and transplant that in the emergence of a pandemic such as we have now. So the SARS coronavirus to novel coronavirus emerged in 2019 and quickly became a global pandemic. The total confirmed cases is over 6 million now. What I wanted to highlight here on this slide particularly is that the SARS coronavirus 2 virus fits in this family of beta coronaviruses next to its cousin, the SARS coronavirus, and very closely related to MERS, for example. And so highlighting of that helps us to think about how we think about vaccine development strategies for the pandemic preparedness. And so vaccine development strategies for pandemic preparedness come in 3 different flavors, so to speak. The first of which is highlighted is the prototype pathogen approach. And what that means is that over time, research on a known prototype virus within a given family will give us enough knowledge that can be applied to viruses within that family. And then furthermore, taking it a little bit further, is that countermeasures for that prototype virus through phase 1 clinical trials will help for the speed of development on the onset of a pandemic. And we wrote a recent viewpoint on this pandemic preparedness strategy. So to highlight some of the VRC's previous coronavirus work, I just wanted to take a step back and look at the SARS coronavirus vaccine development efforts at the Vaccine Research Center. So SARS coronavirus 1 was discovered in March 2013, and it took us a year later to have a SARS coronavirus vaccine that was inducing antibody responses, and then another about 7 months to have that into a phase 1 clinical trial. So this is over a year to get a vaccine from the time that a virus is discovered all the way through to a phase 1 clinical trial. What we did recently in the onset of the SARS coronavirus 2 pandemic is initiate a rapid response. Highlighted here on the far left side is the amount of extensive work that we did on MERS and other coronavirus vaccine development to inform the trajectory towards the current product that's in development. So when the virus sequence was published on January 10th of this year, we immediately initiated a vaccine response in collaboration with Moderna, whereby sequences of the optimal antigen that we'd previously designed for MERS were transplanted into the backbone of the SARS coronavirus 2 vaccine platform. And then, for a long story short, 65 days following the sequence release, the phase 1 clinical trial for this product began. And as of this week, we're currently into phase 2 testing with this product, with plans of going into phase 3 testing in July. And so I want to highlight for this presentation some of the work that went into the prototype pathogen platform or antigen design studies that we did previously. And so the SARS coronavirus, or any coronavirus, has a spike protein on the surface. It serves as a crown on the surface that mediates attachment and fusion to host cells. I have the schematic here just to show you that several of the coronavirus spike proteins are fairly well aligned with each other, which means that to us, when we're developing antigens for these, if there are antigens that are optimal for one, it is likely, if their mutations are right, that we can transplant those mutations into another to make the optimal vaccine antigen. And so the way that we think about making these vaccine immunogens best is a process where you mutate the protein, which is a fusion protein, to be stabilized in its pre-fusion conformation. There is a long history of this type of these types of studies, with fusion proteins that are akin to the coronavirus fusion protein. And I highlight here on the far right, the respiratory syncytial virus fusion protein that really serves as a proof of concept for stabilizing these types of proteins in their pre-fusion conformation to improve immunogenicity. And so you can see here that on the left-hand side, this RSVF protein in its post-fusion conformation is elongated, and the red, which is the place where the most potent neutralizing antibody epitopes lay, is occluded. However, in a pre-fusion conformation, those epitopes are on the top of the fusion protein, and thus, if you were to deliver this protein versus this protein, you get better immunogenicity in animal models and also been shown now in clinical trial. So we wanted to do the same kind of thing with coronavirus spike proteins, and part of doing that is really understanding on an atomic level what the details of the protein are. And so on the onset of my research fellowship, we solved the first human coronavirus spike protein structure in collaboration with Scripps and Jason McClellan's group, which is now at UT Austin, but was then at Dartmouth. After that, there's a slew of publications of really high resolution structures for coronavirus spike proteins. But what I'm going to highlight today are the findings that came out at the same time, inclusive of our study, where we show the rationally designed pre-fusion MERS coronavirus spike antigen. And so how do we use structure-guided stabilization of pre-fusion MERS to guide us towards the SARS coronavirus vaccine antigen and platform that we're using today? So firstly, the HKU1 sequence for that first human coronavirus spike protein that we solved the structure for is really akin to the MERS and SARS sequence, particularly in this region here, or sitting around the fusion peptide. So we scanned in this region and found 2 mutations that sit here in the top of the apex of this spring. If you remember the toys from back when you were a kid, the springy toys. So if we were allowed to put 2 mutations here that are 2 proline mutations, we can lock that spring and then effectively prevent the protein from flipping into its post-fusion conformation. So you can see here that the wild-type MERS protein readily flips into its post-fusion conformation, whereby the 2p mutation allows the protein to be stabilized in this more mushroom pre-fusion conformation. So this allowed the proteins to be expressed better in cell culture, which is something that is very important as you think about vaccines development. And then also it revealed that the structure was in its pre-fusion conformation. Next, we tested the immunogenicity of these proteins in mice. And so we compared an S1 monomeric protein. So this is just a small protein that is essentially a monomeric region from the top of the spike protein, comparing that to the S wild type versus the stabilized pre-fusion version of the protein. With that, in mice, you can see that the red line, which is the pre-fusion stabilized version of the protein, elicits better neutralizing antibody responses, not just to the autologous MERS coronavirus strain, but then also to homologous strains that are closely related to that strain. The interesting thing, as we think about plug and play, so to speak, is that these 2p mutations effectively stabilized the proteins for multiple coronaviruses. And so I'm just showing here endemic human coronaviruses OC43 and 229E. We were also able to use those mutations to stabilize porcine coronavirus spike protein, and then the potentially emerging coronavirus at that time, which was named in those first 2 articles that I showed on my second slide, the WIV1 protein, which is akin to the SARS protein. As well, on the onset of this pandemic, what was very clear looking at those sequences on the 9th of January the 10th is that the sequences align fairly well, about 80% conservation between SARS-CoV-2 and SARS-CoV-1 in the spike protein region. A lot of that conservation was around the area where the 2 proline mutations would reside. And so we transplanted those mutations into the backbone of the SARS coronavirus 2 spike protein. About a month later, solved the high resolution structure of the pre-fusion SARS coronavirus 2 spike protein in collaboration with the McClellan lab at UT Austin. And what was also very interesting about this entire process is that not only as we were looking at the immunogenicity of the protein in its soluble form, which could also be delivered as a vaccine, but generally takes a lot of time to manufacture and thus would not be necessarily ideal for a pandemic situation. So thinking about mRNA or genetic-based platforms, we started to collaborate with Moderna, which is a company that uses messenger RNA as a therapeutic, or in this case, as to deliver vaccine antigens. So we used the stabilized prefusion MERS coronavirus spike protein by the mRNA, and showed also that the S2P version elicits better neutralizing potential than the wild type delivered by mRNA. And so the idea behind the coronavirus vaccine development, which you probably have heard or seen, is called the mRNA 1273 vaccine, is that this new therapeutic protein, in this case, the stabilized prefusion SARS coronavirus spike protein, could be used for an mRNA sequence and manufactured in a lipid nanoparticle and then delivered very quickly into a human. And so the manufacturing process for this timeline is shortened because you don't necessarily have to vet the protein, but only the sequence of the mRNA. And so, you know, as we think about coronaviruses, and I think one of the things that is highlighted in this pandemic is that the onset of other pandemics is likely looming, maybe not tomorrow, but in the future, it is very likely that other emerging infections, coronaviruses or otherwise, could emerge into humans and cause this kind of devastation globally. And so we are moving our efforts and starting to think about a universal coronavirus vaccine. And so what that means is that not just having a universal solution that you can essentially plug and play, but having a vaccine that you may be able to deliver to someone and immunize them against future pandemic threats. And so we are doing things such as designing optimizations in our antigen design to hone into those cross-reactive epitopes, displaying the proteins in various ways, such as self-assembling nanoparticles, which allows for the body to see the protein in a different way and perhaps hone the response. You can also sometimes use these nanoparticles to display multiple coronaviruses, so you can immunize with one vaccine, you can immunize against multiple coronaviruses. And then also, as we've proven with the mRNA platform delivery, is that using gene-based delivery shortens the timeline for manufacturability and then also towards phase 1 clinical trials. And so with that, I'd like to thank the team for which I'm the scientific lead, my PI, Dr. Barney Graham, and everyone else who's worked on this project for years alongside us. It has become a large BRC-wide effort now, so all of inclusive is not on this particular slide. We're obviously social distancing, so we can't take any new pictures. And then also the contributors and collaborators along the way, whether it be our vaccine partners, particularly here, Moderna Therapeutics, the NIAID, which has been running the phase 1 clinical trials, all of the structure studies done in UT Austin and the Scripps Research Institute, and then moving forward towards our universal designs, nanoparticle designs, etc. And that is it for me.
Thank you so much, Dr. Corbett. That was some truly impressive work and a very impressive timeline as well. So we do have some questions for you. First off, you showed how great this technology is for increasing immunogenicity in the context of vaccine development. Has it been investigated at all whether this could be used to improve LFA or ELISA testing?
So yes, actually, this particular protein was actually just put into a preprint where it's called in the publication, it's called the BRC spike, and it's compared to multiple ELISA antigens. The senior author is Caitlin Sadler, if you want to look it up. But so it's been shown that the homogeneity of these two P mutations, particularly expressed in how we express it in our plasmid and et cetera, as we have been for years, like for example with MERS or SARS, gives you a homogeneous construct that you can use for ELISAs. The good thing about the sensitivity on, for example, serology assays like ELISAs with the full spike as opposed to the receptor binding domain, is that you get a all-inclusive view of antibodies that one might be eliciting to all of the domains of the spike protein, as opposed to just the receptor binding domain. And I think people have shown that a few times in manuscripts where the sensitivity to the full-length spike is better than the receptor binding domain.
Very cool, thank you. And then I'll just do one last question here. Sorry, I'm just choosing, there's a bunch. We'll probably get back to you in the panel discussion. What is the shelf-stable temperature for liquid nanoparticle encapsulated mRNA? That was a very specific one, sorry.
No, it's fine. That's actually one of the pitfalls, and I get this question a lot because I'm assuming people know that that's one of the pitfalls. But it is, has to be stored at least minus 20, but alongside all of the efforts in this kind of rapid response, there are efforts to optimize that, to make it better. At minus 20, it could last, a long time, but at 4 degrees, at least for the things that we use in mouse studies, if we were to thaw it, we would only want to use it for 2 weeks.
Great, awesome, thank you so much. So finally, I would now like to introduce Dr. Carolyn Calfee. Dr. Calfee is a world-renowned researcher of acute respiratory distress syndrome, a type of respiratory failure that is characteristic of severe cases of COVID-19. She is leading an interdisciplinary team at UCSF to identify predictors of COVID-19 disease severity and clinical outcomes.
Great. Thank you so much for the invitation to participate in this symposium and to be part of this amazing panel with such impressive scientists. I really appreciate the opportunity. So I'm going to talk today, pardon me, I'm going to talk today about ARDS, and since many of the people on the call may not be clinicians, I'm a pulmonary physician and a practicing intensivist as well as a physician scientist. But since many of the folks on the call may not be clinicians, I'm going to talk about what ARDS is and why you should care in the context of COVID-19. And then I'll talk about some of the work that our group has been doing over the past several years focused on biologic and clinical heterogeneity in ARDS, evidence for ARDS subphenotypes with distinct clinical outcomes in response to treatment. We'll talk for a moment about how that may relate to COVID-19, and then I'll close with some discussion of the prospective COMET study that we're working on here at UCSF. So this figure is taken from the San Jose Mercury News in April 2020. And just to blow it up here, since we're all looking at this on small screens, it says how COVID-19 kills ARDS, the acute respiratory distress syndrome, which is the lung disease triggered by COVID-19. And as you can see here, it says for people with ARDS, the lungs fill with fluid, breathing becomes impossible and oxygen levels plunge. The only cure is time. Not entirely true, we'll talk about that, but artificially breathing for the patient until the inflammatory fluid subsides. So ARDS is really the type of respiratory failure that patients with COVID-19 experience, and in many cases, unfortunately, die from. But ARDS is not unique to COVID-19. So this is taken from the original description of ARDS, which was published now 53 years ago in The Lancet, back when you could publish a 12-patient case series in The Lancet, although I guess we're sort of back to those times now again with COVID-19. But these authors described a clinical syndrome of bilateral radiographic opacities consistent with pulmonary edema, hypoxemia, stiff lungs, that the syndrome was not primarily due to heart failure, and that it occurred in the setting of a primary insult or risk factor. And in this case, it could be pneumonia, sepsis, or severe trauma. In the case of COVID-19, clearly viral pneumonia. Now, this is the current definition of ARDS, which was published in 2012 in JAMA, and really has changed very little from that time period. ARDS is a syndrome, as you can see from what's shown here of acute respiratory failure within 1 week of a known clinical insult with bilateral radiographic opacities. Respiratory failure is not fully explained by cardiac failure or fluid overload, and it may be mild, moderate, or severe as rated by the oxygenation impairment. ARDS in general is very common, and unfortunately mortality is quite high. So this is the best epidemiologic data we have on ARDS prior to COVID-19. It was taken from a cross-sectional study conducted in 435 hospitals from 50 countries around the world during 4 weeks in winter 2014. Almost 30,000 patients were admitted to the ICUs during this time period, and ARDS represented 10% of those cases. The figure on the right shows the probability of hospital survival by ARDS severity, and you can see here this is 28 days, so by 1 month, between basically 30 and 40% of patients admitted with ARDS were no longer alive. So outcomes are clearly not what any of us would hope for. We've learned quite a bit about the pathophysiology of ARDS, and I'm not going to go into this in great detail here, just to highlight a few key points. Sorry, my screen is misbehaving here. This is a single alveolus model of the lung with the normal alveolus on the left-hand side, and the right-hand side shows what's happening in ARDS, which includes injury, apoptosis, or necrosis of the lung epithelial lining layer, the lung alveolus filling with inflammatory pulmonary edema fluid with a number of different immune cells elaborating different cytokines and injurious mediators. You see here damage to the vascular endothelium with leakage of contents from the plasma into the alveolar sac, which is what causes the alveolar flooding, as well as endothelial injury. And importantly here, as this has been talked about quite a bit in COVID-19, intravascular coagulation and platelet activation as a key element of this syndrome. So if we understand the biology well, what have we done in terms of identifying pharmacotherapies for ARDS? And unfortunately, this is just a partial list of some of the many different agents that have appeared to cure mouse ARDS, but have failed when taken to human studies. It probably represents tens or hundreds of millions of dollars, as well as tens of thousands of patients enrolled in clinical studies, and yet no benefit has been found. So why is that? Is that because we've been studying the wrong drugs, the wrong patients, or the wrong study design? And I would ask whether all the patients that we're lumping under the syndrome of ARDS really have the same biology. So these are 3 patients that were enrolled in one of our clinical cohorts of ARDS at UCSF, a 74-year-old man with multiple myeloma and pneumonia, a 37-year-old woman with cholangitis who received 2 units of fresh frozen plasma for her cholecystectomy, and a 24-year-old woman who had a cardiac arrest and aspiration of gastric contents. And you can see just from their radiographs that they're quite different. And if you think about their clinical risk factors and the potential biology involved, they're also quite different. What about these 2 patients? Do these 2 patients who both meet criteria for ARDS, do they have the same biology? Well, so the patient on the left has vaping-associated lung injury, which was the ARDS mini epidemic that we had in the fall of 2019, as you may remember. And this patient on the right has COVID-19. So clearly, the same biologic processes are probably not going on, yet we're trying to treat the patients with the same therapies. So this gets back to sort of a classic conundrum in medicine of whether we should be lumping and splitting. And now we can use the fancy term of precision medicine when we talk about splitting, which sounds better for grant applications, sounds much fancier and more highfalutin. But the oncologists are pretty far ahead of us in critical care. They have already tackled, in many cases, understanding clinical and biologic heterogeneity within syndromes. If you think about breast cancer, we don't think about breast cancer anymore as one uniform disease. We think about hormone receptor status. And then they've used those approaches to design clinical trials that can target specific subsets. So we wanted to take some of these approaches into the ICU and think about how we could apply them to patients who are critically ill. So we've been using an analytic approach called latent class analysis, which is a form of mixture modeling, which is based on the hypothesis that there are distinct subclasses within broader groups of patients. And if you see the figure on the right, you ask whether this data distribution in the solid line here better fits with the hypothesis that this is one class of patients, or instead 2, 3, or 4 classes. And now with modern computing, we can ask that question of dozens of different variables simultaneously and actually test a hypothesis regarding the best fitting number of classes. And unlike typical regression type of analyses, this can be independent of clinical outcomes. So you can just look at the data for patients at baseline when they come to the ICU, for instance, with ARDS, and ask just within that baseline data, do we see evidence that there are distinct subgroups of patients? So we have applied this approach now to 5 different data sets from 5 randomized controlled trials of ARDS, all of which actually were published in the New England Journal. And in all 5 of these RCTs, we found strong statistical evidence that a 2-class model or a 2-subtype model was a better fit for the data than a 1-class model. We used clinical and biomarker data from pre-randomization only. And about 70% of the patients fell into a group that we've termed hypoinflammatory for reasons I'll show you on the next slide, and about 30% hyperinflammatory. Though those names are really, in some ways, I kind of regret applying those monikers to them because we don't really understand the true driving factors of pathogenesis. Importantly, ARDS risk factor does not discriminate between subphenotypes. And since we're talking here about COVID-19 as today's topic, I'll just highlight that patients with pneumonia were basically evenly divided between these 2 subtypes. So of course, this includes patients with both bacterial and viral pneumonia. So this figure compares the continuous variables, which are here along the x-axis, in the 2 subtypes, with the y-axis being the standardized variable value, where the mean is set to 0 and the standard deviation is set to 1. And that basically just descales the variables so that variables with a very large range are not automatically at the extremes of the figure. And this figure is ranked so that the maximum positive difference between the subtypes is here on the left, maximum negative difference here on the right. The red line represents the mean values in the hyperinflammatory subtype, and the blue, the hypoinflammatory subtype. And the reason that we gave this the name hyperinflammatory is because here on the left-hand side, you see that this subtype is marked by higher levels of interleukin 6 and 8, TNF receptor 1, and PI1, all of which are really inflammatory cytokines. This group is also marked by lower levels of bicarbonate, so the patients were acidemic, protein C, which is a marker of disordered coagulation, and systolic blood pressure. This figure shows the mortality across all 5 of the randomized controlled trials I mentioned, stratified by phenotype. And what you can see here is that although we did not include mortality in the class modeling, right? So these groups were not identified on the basis of different outcomes. The mortality is really markedly and statistically significantly worse in all 5 of these cohorts in patients in that hyperinflammatory group. So obviously this is a group that has prognostic implications, but there's lots of different ways to identify prognosis in these patients. And I think the reason that we've been particularly interested in this work is because we actually, in secondary analyses of these RCTs, were able to observe that these 2 subtypes seem to respond differently to mechanical ventilation, to fluid therapy, and to pharmacotherapy. So let me just show you that data briefly. So the clinical trial, the alveoli clinical trial, compared a high to a low PEEP strategy. PEEP is one of the variables we sent on the mechanical ventilator. It's the end expiratory pressure, so the pressure that as the patient is breathing out, that basically helps to hold the lungs open. And this was a negative study of 549 patients. But what we found when we asked if there was evidence of response to randomly assigned PEEP within either subphenotype is what's called an interaction, which means that the effect of PEEP differed based on the subtype. So you can see here that in the hypoinflammatory group, which again is the larger group, mortality seemed to be higher in the high PEEP arm, and the pattern was actually the opposite in the hyperinflammatory group, suggesting that these 2 subtypes seem to respond differently to this randomly assigned therapy. We also tested this approach in the FACT trial, which compared a fluid liberal to a fluid conservative strategy. Again, this trial showed no mortality difference, but more ventilator-free days, so more time off mechanical ventilator in patients randomized to the fluid conservative arm. And what we found again here was that the effect of fluid therapy on death seems to differ by subphenotype. So in that hypoinflammatory group, that larger group, the fluid liberal strategy was associated with higher mortality, and the opposite pattern was observed in the hyperinflammatory group. And importantly, it didn't seem that subphenotype was just a surrogate for severity of disease, because we didn't see similar interactions with Apache score, which is basically a summary statistic that summarizes severity of disease. Most recently, we've tested this in a clinical trial of pharmacotherapy. So this was the trial of simvastatin for ARDS. You may wonder why we're giving a cardiac drug for ARDS. It's because of that endothelial and inflammatory component to this syndrome that I mentioned on the prior slides, and really some pretty compelling data in phase 2 studies as well as in animal models. But unfortunately, this clinical trial was yet another negative clinical trial, and you can see the survival curves from the original publication, which are superimposed on top of each other. However, when we did a secondary analysis and we stratified this by subphenotype, what you can see is that if you were in the hypoinflammatory group, shown here in the 2 blue lines, there was really no effect whether you were randomized to placebo or simvastatin. But if you were in this hyperinflammatory group here, patients on simvastatin had significantly improved survival at 28 days compared to the hyperinflammatory patients that were treated with placebo. Now, all of this that I've shown you is secondary analysis and certainly needs prospective validation. But what it suggests is that there are distinct subtypes within this heterogeneous syndrome that may respond differently to treatment. We're working in our group on making identification of these phenotypes at the bedside practical. Obviously, you can't take 35 variables like we did for latent class analysis and perform this at the bedside. So Pratik Sinha, who's a terrific postdoctoral fellow in my group, has been working on this. He combined 3 of these RCT cohorts into a data set of over 2,000 patients and used a variety of machine learning methods, including random forest, lasso regression, and bagging to identify the most important 6 variables. And then took those 6 variables and put them into regression models in order to classify patients. He locked the coefficients in this derivation data set and then validated the models in 3 independent separate ARDS trial cohorts, of which I'm just going to show you one. So this data was just published earlier this year in Lancet Respiratory Medicine, and what we found was that either 3 or 4 variable models composed of 2 sort of research biomarkers like IL-8 and protein C, and in the case of the 3 variable model, 1 clinically measured biomarker, bicarbonate, performed quite well. So the areas under the curve here for the 3 variable model are 0.94, and for the 4 variable model are 0.95. So suggesting that once we can develop real-time bedside assays for these biomarkers, it would be feasible to identify these subtypes for clinical use. So what are we working on now? We're doing additional mechanism-focused studies of both candidate markers as well as discovery approaches to try to understand what's actually driving the differences between these subtypes. We're interested in studying heterogeneity in the immune phenotype. We're working on real-time assay development and prospective studies, as well as studying real-world patients outside of randomized control trials. And then I think a question that we've been working very hard on for the past couple of months is how COVID-19 fits into this biologic heterogeneity. Viral ARDS, as I mentioned, has been a part of this syndrome since its original description 53 years ago. And understanding whether COVID-19 where COVID-19 fits into this biologic heterogeneity may be really important for identifying effective therapies. I'm just going to show you a little bit of data on this, but you may have seen these reports. This is from the New York Times, reporting on cytokine storm in patients with COVID-19. And attempts to test immunomodulatory therapies based on the idea that cytokine storm is a major contributor to the morbidity and mortality that we're seeing. So I don't have a ton of data here to show you, but I just want to show you this one table from a commentary that we've written that's now in press for JAMA Internal Medicine, which seems to suggest that if anything, plasma IL-6 levels, and IL-6 is one of those biomarkers that I showed you as part of the sort of hyperinflammatory phenotype. If anything, plasma IL-6 levels in COVID-19 related ARDS are actually lower than those in typical ARDS. So the top part of this table shows IL-6 levels in patients with COVID-19 overall here in the total population, and then in patients with severe disease here on the right. And you can see that these levels, and these are medians and interquartile ranges, range from about 7 picograms per mil to about 64 picograms per mil as median. In contrast, if you look down at the bottom part of the slide, these are plasma IL-6 levels in patients with ARDS, and you can see that they're actually orders of magnitude higher. And if you look at the hyperinflammatory phenotype, we're actually talking multiple levels, orders of magnitude higher. So this really suggests that if IL-6 is representative, that this whole idea that there's actually severe cytokine storm in these patients may be very misguided. There's all sorts of potential limitations and caveats to this. In particular, measurement platforms are different from clinical lab to ELISA, and certainly plasma circulating levels may not represent what's actually going on in the patient's lung. But I think, if anything, this should raise some concern for us that potentially the cytokine storm that's been advertised may not be supported by the data. All right, so in the last couple of minutes, I just want to transition to talking about the COMET study, which is a prospective study that we've been working very hard on here at UCSF to try to understand the immunophenotype of patients with COVID-19, as well as some of these questions around biological heterogeneity in COVID-19 ARDS. And COMET stands for COVID-19 Multiphenotyping for Effective Therapies. This study was initiated by a request from NIAID on March 18th to participate in the IMPACT study, which stands for Immunophenotyping Assessment in a COVID-19 Cohort, which is a multi-site consortium at 10 sites around the United States. The goal of the consortium is to carry out host immunophenotyping to identify features predictive of COVID-19 severity or progression, and ultimately to inform the development of novel therapies. Enrollment started on April 6th, and we were officially activated as a NIAID IMPACT site on May 6th. The study basically is enrolling hospitalized patients who are admitted to UCSF hospitals, Mount Zion, Parnassus, or San Francisco General with suspected or confirmed COVID-19. We're collecting a wide array of biosamples, including blood, urine, nasal swabs, and endotracheal aspirates, and the following enrollment schedule that you can see here, with more intensive collection for hospitalized patients, and then subsequent every 3 months collection as outpatients. We've enrolled 120 patients to date, roughly 80% of whom are COVID positive. And importantly, we have a really amazing multidisciplinary team from across UCSF, including many people from ImmunoXX. Many of us have never actually met in person. We've come together in this new shelter-in-place environment. Online. You can see a full list of our team members here at our study website, and we're working hard to enroll patients to try to understand the biology, and we'd welcome collaboration and involvement from others. So with that, I'll just close with some take-home messages. ARDS is a syndrome characterized by non-cardiogenic pulmonary edema, the need for mechanical ventilation, and high mortality. It's the common form of respiratory failure and in many cases mortality in patients with severe COVID-19. We have extensive evidence that biological heterogeneity may influence ARDS treatment response, but we've really only scratched the surface of understanding this heterogeneity, and we still have much to learn about COVID-19 ARDS and its biology. And with that, I'll close, and I'd be happy to take any questions.
Thank you so much, Dr. Calfee. That was a super interesting talk and very timely work. I'll just direct one question to you before we get going on the panel session. Considering your commentary on IL-6 levels in plasma being lower in COVID-19 patient versus classic ARDS, would you like to comment on the ongoing anti-IL-6 therapy effort?
Yes, really thoughtful question. For those of you who are not familiar with this, there are multiple ongoing clinical trials of either IL-6 receptor antagonists or monoclonal antibodies that block IL-6 with the idea that these therapies may be helpful in ameliorating the cytokine storm. So this is kind of the subject of the commentary that that table was drawn from, which you know, I hope will be out soon. But I think it's absolutely possible that immune modulatory approaches may be helpful in some patients with ARDS. There is a long history of attempts to block specific cytokines in both ARDS and sepsis, which is closely related. And really a couple of decades of clinical trials trying those approaches, which were pretty much uniformly failures. That's not to say that there may not be a subset of patients who benefit, and that's not to say that you know, these patients may not benefit as well. And I eagerly await the results of the clinical trials. But I do have a lot of concern that there are potential downsides to that approach as well. Those therapies tend to have very long half-lives. And we know that critically ill patients, these patients with COVID-19 related ARDS, are hospitalized for a long time. They have long durations of mechanical ventilation. And they're at high risk for secondary infections. And I really do worry about abrogating the immune response in a very long-lasting way in these patients, and the consequences that that may have for their ability to fight off the development of secondary infections.
Makes sense. Okay, at this point, I'd just like to thank you and all of our speakers for such great presentations and taking time to share your research with us today. My colleagues, Rachel and Julie, will now continue with moderating the question and answer panel session.
Thanks, Casey. Hi, everyone. My name is Rachel DeBarge, and I'll be joined by my fellow graduate student, Julie Garcia, to moderate this question and answer session. Over the course of the symposium, we've compiled a list of questions that we'll be directing towards our speakers, and we also encourage attendees to continue to submit questions as they come to mind. So now I'll ask our speakers to rejoin us via video, and we can start asking some questions. So I'll start first with Dr. Marquez, who has been going through and answering many questions in the question and answer feature, so I appreciate that. But a particular question that came up was, what are some policies and infrastructure changes that we can develop to ensure the safety of vulnerable populations in San Francisco and also maybe beyond San Francisco to help vulnerable populations such as people of color, the LGBTQ community, and their homeless communities?
Great, thank you so much. It's a great question. I mean, I don't profess to know the answer for all vulnerable populations. I think, you know, based on my work, I think this goes through this goes to everybody, is really I think that the trust component is a key component, and so really involving community leaders and community groups to help sort of design and sort of and lead the interventions that are needed. So from the testing component, really addressing some of, you know, at least for the Latino community, you know, some of the impacts that this could have on immigration, and just sort of reassuring that this, you know, questions that came up very commonly were about public charge, and sort of reassuring that this wouldn't be an issue. And I think the trust was built just because they saw, you know, their community there at the testing site. So I think those kind of things are very helpful. And then I think the big issue is sort of the wage replacement. And so the financial ramifications of just COVID in general are so massive for vulnerable populations. But I think the fear that if you're positive, you may not be able to go to work, and you are the primary breadwinner of your for your family. So we need to be able to say as a community that we will support you, and, you know, during this time period, because if you don't, people aren't going to want to test. And I think that sort of low barrier testing is key. So I think there's been a lot of steps forward in to move those legislations forward. And I think the other component is like bringing testing to the communities. I think, you know, in San Francisco, there's been a lot of, improved access to testing, but still a lot of testing is sort of out, you know, further out of the Mission. There's one great testing site at Mission Neighborhood, but that just recently sort of started. And so bringing testing to where people are. And then I think with the D10, the Bayview testing this weekend, they're doing, it's called D10 Unhoused. And so they're actually having in one of the parking lots of one of the shelters sort of a testing campaign, and then going to go out, kind of involve street medicine to go out to the households to do, or to the tents, for example, and notify positive. So it's like really bringing tests to where the people are, and and tying it with where people are to trust their community members. And then I think the financial support is also a big component.
Great. The next question is actually for Dr. Corbett. What is known about the SARS coronavirus 2 spike protein homology from this epidemic? And are those sequences that were originally isolated in Wuhan homologous to those that are isolated, for example, from New York City?
Yeah, so the diversity of the spike protein across all of the isolates around the globe is very minimal. We obviously track this, right? Because the sequence for which we have in our vaccine is one of the original isolates from Wuhan, China. There have been a couple of papers showing particular mutations that people think could be influential. By modeling those mutations on the spike protein, they are not surface mutations, which means that they likely are not targeted by the types of antibody responses that we would elicit with our vaccine. Nevertheless, just an all-inclusive point is it's fairly well known that coronaviruses have proofreading mechanisms, and the mutation rate is not as quick as what people would think about, for example, for like an HIV or something like that, right? So all of the sequences that have been isolated in the world for coronaviruses probably could make up one person's sequences who is an HIV patient, right? The mutation rates are not necessarily alarming right now. But of course, we'll be testing, antisera from our vaccinees against some of the spike proteins that have been shown in publications to have mutations.
Awesome, thank you. I also have another question for Dr. Corbett. In a situation where there's not a global pandemic and there's more preventative vaccine development being done, are there advantages to using nucleic acid-based vaccines versus protein vaccines, such as when you may want to use one format over another?
Yeah, absolutely. I mean, so each different type of vaccine platform has its different advantages, right? So nucleic acids, manufacturability, particularly for mRNA vaccines, you get T-cell responses that may not necessarily be as robust with, for example, protein vaccines. Whole inactivated vaccine technology is tried and true, has been used forever, and so people trust it. So that's one advantage of that. So there are advantages. So we have lots of work. So I've actually published some like flu protein vaccine stuff. We have lots of work in the protein arena. Don't know what our trajectory is for taking a protein, particularly into the clinic at the Vaccine Research Center, but there are subunit protein vaccines being made for SARS coronavirus 2 as well.
Great. And so the next question is for Dr. Calfee. I'm not sure if you can answer this question, but are there good animal models that capture COVID-19 ARDS that we could be using as we're trying to develop therapies?
Yeah, that's a great question. So there are not, to my knowledge, traditional models of coronavirus-induced ARDS, though I think certainly models could be done with adapted versions of the known pathogenic models. There are many different animal models of ARDS. It's a topic of great controversy, actually, because ARDS is such a heterogeneous syndrome. So if you model, let's say, influenza, and you get a mouse that develops acute lung injury, hypoxemia, pulmonary edema, are you modeling ARDS? Well, you're modeling influenza-associated ARDS. But what about LPS inhalation, or what about cecal ligation and puncture. And so many times in the ARDS field, people want to see multiple different animal models. So I think that probably it will be useful to develop a, specific adapted model of this particular coronavirus to mice. I don't know that that's been done, but it's a challenging field because ARDS is so heterogeneous.
Great. Next question will be for Dr. Yu. I know we touched on this a bit during your talk, but do you think it's important to develop a unified protocol for serological testing in California or broadly in the United States or worldwide? Or if there are efforts being done to do this currently?
I guess it depends on what you mean by a unified protocol. So a lot of the efforts now actually have moved away from the lateral flow assays to more standardized platforms. And I think those have much higher sensitivity and specificity. So I think that some of the concerns that I had raised would not be as much of an issue. As far as, say, like lateral flow assays, we've even talked about, it would be nice to have a standardized reader, like a densitometric analysis, maybe an iPhone app that could standardize reading of the bands so that you don't have to deal with reader variability. And I know that actually several groups have contacted us to try to work on that. And they're trying to get photos to develop these iPhone assays that would reduce those issues.
Great. So again, this next question is for Dr. Calfee. You spoke a little bit about the IL-6 therapies or anti-IL-6 therapies. Kind of on the flip side of that, do you think immune activating treatments are likely to be effective, or are there other concerns as well using things like checkpoint inhibitors? And this is for COVID-19, of course.
Yeah, it's a great question. And I think we have known since ARDS was first identified in that Lancet article in 1967, the case series of 12 patients, they said, oh, corticosteroids appear to be of some utility, right? So there's been this knowledge that part of what we're seeing in ARDS from the beginning has been sort of collateral damage from the immune response to invading pathogens or different types of trauma. But how to best modulate that and where to specifically intervene, I think, is unknown. People are still trying steroids in ARDS, right? 53 years later, and we still don't have a good consensus on that. So if that gives you a sense of how challenging it is that we've been working on that one question, steroids in ARDS, for 53 years without success, right? I do think, though, that if there's any silver lining to this situation, it's that I think it has generated more interest in trying to understand the immune phenotype in these patients and sort of the contours of that over time, the diversity within it and the contours over time, so that may help us identify in whom we're seeing primarily, for instance, viral or pathogen mediated damage versus in whom we're seeing primarily collateral damage from the sort of overexuberant immune response. But I think it's very unlikely that a one-size-fits-all approach is going to be broadly effective in ARDS. Now, if we focus just on COVID-19 and we think of this as severe viral lung injury, I think we may have more utility. But even within COVID-19, we have some preliminary data, and I think others are generating data that there's still quite a bit of heterogeneity within that.
So our next question is for Dr. Corbett. And the question that came in was, is the Moderna vaccine platform able to induce mucosal immunity? And in general, has that been considered in some of these COVID-19 vaccine approaches? You're muted currently, just so you know.
So there are people who are thinking about mucosal immunity because obviously it's a respiratory virus. We're delivering this vaccine intramuscularly. And it is not likely that there will be robust mucosal immunity. So we haven't been really assaying for any mucosal immunity thus far. But there are people who are thinking about nasal vaccination, intranasal vaccinations, etc.
Great. So again, Dr. Calfee, the question is there a relationship between weight or BMI and negative ARDS outcomes? And I would also expand that to, I think there's a lot of concern right now about the chronic underlying conditions that patients have. And do we see that with ARDS correlating between your outcome?
Yeah, so what a great question. So there's definitely emerging literature in the setting of COVID-19 that specific comorbidities seem to be associated with poorer outcomes. So in general, obesity, hypertension, coronary disease, chronic lung disease do all seem to be associated with poorer outcomes. In general, obesity in critical care has been a little bit of a paradoxical situation in that it sometimes actually seems to be somewhat protective. But so far in the data that I've seen coming out on COVID-19 specifically, it seems to be associated with poor outcomes. And how much of that is due to sort of underlying frailty, how much of that could be related to different medications, et cetera, I think all still needs to be worked out.
Great. Another question again for Dr. Corbett. There are many coming in. One of our attendees was curious when there may be data on how well phase 2 of the vaccine trial has gone, and assuming all goes well with phase 3, when vaccine would be available to both frontline staff and high-risk patients versus the general public. That's known.
So phase 2, the first person has not even been dosed yet, so I can't comment on that. There was a press release around the data, and the data should come out soon for the phase 1 trial. And the availability of the vaccine, the hope, and from the beginning, we said 18 months from sequence to vaccine. And so for the general public, that would mean by next spring. The trajectory is far more advanced than that right now. But again, we're right at the end of phase 1 and beginning of phase 2. So, you know, things could happen. But the hope is still at the very least by next spring.
Great, so I think we have time for just maybe 1 or 2 more questions. A question that just came in, Dr. Calfee. Could you explain how ARDS patients have increased blood coagulation, and why are we seeing some COVID-19 patients dying of stroke?
Great question. So we've known for a long time that in ARDS, the development of microvascular thrombi is part of the pathogenesis of the disease. So back in the 1980s, they actually did pulmonary angiography on these patients with ARDS, where they injected dye into the pulmonary vessels, and you can see that there are microscopic blockages. So overall, we know that endothelial activation and disordered coagulation and fibrinolysis are fundamental elements of the pathogenesis of the syndrome. Now, there have been a lot of reports suggesting that the increase of thrombotic complications is higher in patients with COVID-19 than with other types of ARDS. And I think we're starting to see emerging data that's giving us a broad range. So we know that in critically ill patients in general, around anywhere between 10 to 40% of those patients have thrombotic complications. And that's just from being critically ill, right? And we've seen a wide variety of ranges of this data in COVID-19. So I've reviewed a couple of manuscripts lately that have put the rate of thrombotic complications sort of towards the lower end of that spectrum, 10% or so. And then I've also heard anecdotal stories from colleagues in New York of really horrific thrombotic complications in patients with COVID-19 that seem to fall outside the scope of what we would consider sort of normal or expected for these patients. So I think it's a known part of the biology of the syndrome, and how much more pronounced it is in COVID-19 as opposed to other cases, I think is still an open question.
Great. Well, with that question, I think we're going to wrap up just so that we can finish on time. I would like to thank you all for taking the time to support us and our speakers today. We want to especially thank Drs. Carina Marquez, Ruby Yu, Kizzmekia Corbett, and Carolyn Calfee for presenting today. I think this is really great information. Today's mini symposium was recorded, and we'll be uploading that to our website and as well as on our Twitter page, so you can access and share that with others. Please follow us on Twitter or keep an eye out for a follow-up email that will have more information on the resources that we shared at the beginning of this symposium. We would like to close by again recognizing that we are in extraordinary times that demand our attention and action. While our organization, ImmunoXX Plus, focuses on gender equity, our mission is to promote diversity and equity in science, and that must also include racial equity. To that end, we stand with Black Lives Matter movement, and we will do everything we can in our power to amplify their voices and their mission. We must hold ourselves accountable and our institutions accountable, and we encourage you to do the same. Educate yourself, support your colleagues, and demand change. We hope you have a healthy and a safe rest of your week, and thank you so much for joining us here today.
Thank you.
Thank you, guys.
Thank you.